All right, so we're continuing on the Pharm course, almost done here. This lesson and one more. This one's going to be about the very fundamental skill for everybody about routes of administration. The route impacts the rate of absorption. If you give a medicine IV, it gets in instantly. If you give it IM, it moves in more slowly. We want to talk about all the various routes and their rate of absorption, as well as some other characteristics. So sometimes you can only give a med by a certain route. We don't have a way to give aspirin IV. We give aspirin orally in the field. Other meds, you get a choice of routes. An example would be, say, Narcan. Narcan can be given intranasally, intramuscularly, intravenously, and so you have some choices on your route of administration. Here's a list, kind of grouped. In some way, at least a way that made sense to me, for whatever that's worth. But here's a list of the routes that we want to talk about. The oral, buccal, sublingual, rectal group, and then intranasal, endotracheal inhalation, that kind of group, and then we have topical, subcutaneous, and intramuscular as a group, and then IVIO and IV infusion is how I was envisioning kind of talking about these. So we can give medicines by mouth or a tube that goes down the mouth. And these meds delivered orally, the key thing is that they go through the stomach and then the liver, digestive tract, and they take a while to get in to the bloodstream because they're being metabolized and processed. Aspirin's a real common field medication example of something that we deliver orally. We like the chewable tablets. There are some orally dissolving tablets of ondansetron, Zofran. It's an anti-nausea medicine, one of the most commonly given medicines in the ER, and it's increasingly more common in the field. And now we're learning that there's some oral tablets that will dissolve in the mouth for that patient having some nausea who doesn't have an IV, and you don't want to start an IV just to help them with their nausea. So that's a pretty cool use for the oral route. And then really, if you put a gastric tube down their mouth, an OG, or you put it down their nose, an NG, either way it ends up in their stomach. And so orally basically means given in a way that goes through the stomach. And so I can't think of anything we give OG or NG, but I wanted to include that just to be complete. Now here's my deal. Buccal is really underrated. The buccal route of administration just really doesn't get the play that it ought to. And you know how to give things buccally. It's like people that chew tobacco. It's a pinch between the cheek and gum, because medications, substances, will soak into the bloodstream rapidly through the buccal method, through the mucosa in the cheek and gum. That's much faster than oral because it doesn't go through the stomach. It doesn't go through the liver. It goes directly in. And so glucose paste, which a lot of us have been calling oral glucose for a long time, that really hasn't been helping. Glucose paste is what we ought to call it. It's a very common example, and if you put some glucose paste on one side of the mouth between the cheek and gum, and some more on the other side of the mouth between the cheek and gum, and then maybe a little bit under the tongue for sublingual, you've got a much faster application and introduction of that glucose into the bloodstream than if they swallow it and it gets metabolized in the liver, and it takes a while to work in. So buccal is an excellent route. Sublingual takes advantage of the fact that the area under the tongue is extremely vascular, and so nitroglycerin is very rapidly absorbed via the sublingual route, and that's the most common example. Whether it be a spray or a tablet, nitroglycerin sublingual is a very common route, and that the speed of absorption sublingually is nearly as fast as IV. So it's a very, very good option for field use. Speaking of options for field use, this one's not a good one. We don't use the rectal route of administration very often. The rectal mucosa does give a pretty rapid absorption. In the past, we've used Valium. We've given Valium rectally, particularly for pediatric seizure patients. And I've even seen families that had a child that had seizures, had a seizure disorder, and they would have Valium at home, and they would administer it. We carried it for a while on one of the services here in town, and I believe it was pretty expensive, and it was very, very rarely used. But prior to the widespread use of IO, the prospect of starting an IV on a seizing pediatric patient was pretty scary, and so this was a plan. But really now, I don't think there's anything given rectally in the field. Maybe some places will have some suppositories for nausea. We used to give those in the ER a fair amount, maybe a Phenergan or a Tygan or something like that as a suppository to help with the patient's nausea. But the rectal route is really kind of poo-pooed these days. Ha. Sorry, I just couldn't pass that up. Now we're going to talk about intranasal, endotracheal, and inhalation. Intranasal is really kind of the new and up-and-coming route. Everybody thinks IN is the coolest way to go. And there's some real advantages to it, but there's also a couple of issues. So things are rapidly absorbed through the nasal mucosa. Obviously, that's why cocaine abusers are able to, cocaine users, I guess, are able to get what they get because things are rapidly absorbed through the nasal mucosa. But the problem is runny noses, and you may have a lot of runoff as well. And so just because you put it in their nose doesn't mean it stayed in their nose long enough to be absorbed into their nose. And if there's a whole bunch of snot involved, snot is a lining for the respiratory system, and so you're not going to get, it's a barrier, and it's going to keep medications from getting in. So you're not always going to have a real good absorption, and you may not be sure even how much they got. The general accepted maximum is the volume of 1 cc per nair. So you can give 1 cc up the right side, 1 cc up the left side, and in theory that's your max volume. Some examples, well, Narcan was the first, and it's probably the most widespread, and it's got the most play publicly. Midazolam would be great for seizures, and glucagon in some systems has become an option. So really what you're talking about here is if the overall time to give a medicine IV is going to be too long, then you can go with IN. Well, now, why would it be too long? Well, if you have to get the IV and then give the medicine IV, that may take longer than if you just gave it IN and waited for it to soak in. My problems with it is that I don't really know how much I gave unless I'm pretty sure none of it ran off or they didn't swallow it. And so I'm not sure how much I gave, and I'm not sure when it's going to soak in. Whereas if I give it IV, I know exactly how much I gave and exactly when it's going to soak in. Endotracheal was a route that we used for a long time, and it's been many years since that's been okay. Again, the advent of IO and easy IO and field adult IO, intraosseous lines, has really made endotracheal administration medication less common and unnecessary. The meds were rapidly absorbed through the alveoli as long as the alveoli were open. Spillage was always an issue. It seemed like you squirted some down the tube and a bunch came back up the tube. And in fact, they had us doubling the doses, in most cases 1 to 2 times or more of what you would give IV. You give ET because you know you're going to have some spillage and some irregular absorption. Again, the alveoli weren't always clear. And now, since IO, we just really don't use it very much anymore. Had a pretty cool mnemonic if you were thinking of what medicines can I give toward the navel, down the ET tube, shooting them toward the navel. You had Narcan, atropine, Versed, Epi, and lidocaine. That was a pretty cool one to remember. But now it is a very, very last-ditch effort because we're just not sure how much medication we're actually getting in there. Inhalation is the pretty standard way to get bronchodilators in. And so Epi, ipratropium, racemic Epi is really more of a topical administration, but some of that is also absorbed through inhalation. The idea is that you're trying to get the medication into the bronchioles or down toward the alveoli, and they're absorbing the medicine directly into the bloodstream. Actually, albuterol in a puffer are tiny particles, and they're supposed to go down and actually get on the bronchioles and work directly in that case. So, it's rapidly absorbed through pulmonary tissue. The problem is dead spacing. Well, what's dead spacing? Dead spacing means that the patient is ventilating only the airways, only the non, I really botched that up. Let's try this again. What's dead spacing mean? Dead spacing is that you are only ventilating the trachea and the bronchi, but you're not really ventilating any of the alveoli where the actual gas exchange occurs. So you're really short of breath patient that's not ventilating very well, may be having a great deal of trouble getting air to the alveoli and to the terminal bronchioles, and that's right where these medicines are supposed to go to act. We're going to talk about the next group of topical, sub-Q, and intramuscular. Topical is very rarely used anymore. A lot of services use nitro paste, though. Some rural services that have long transport times use some nitroglycerin paste, and it absorbs through the skin. Of course, it only helps if you have decent perfusion. Otherwise, you're not really sure how much they're going to get and when they're going to get it if their perfusion is poor. And like we said, racemic epi is one of those that's topically administered to swollen upper airways. Even though we give it through a nebulizer, it's not as inhalational as much as it is topical. Talk about racemic epi more when we talk about some different cases. Sub-Q has really pretty much been replaced by IM. We used to give epi sub-Q, but there's very little subcutaneous administration. Now we just go directly into the muscle, intramuscular. The issue was inconsistent absorption. Not really sure when it's going to soak in, if it's going to soak in. So why would I give somebody really sick something sub-Q? Because if they're really sick, they need it right now. And so we've gone to IM or IV on that. So sub-Q is really not in the mix much anymore. IM, only thing I can really think of we give IM in the field would be epinephrine for anaphylaxis. Perhaps maybe some analgesia or something like that, but really for the most part, IM is rarely used in the field. You'll do a fair amount of those in ER clinicals, but not so much in the field. And now we're down to our IV push, which is everybody's favorite because it's extremely fast, almost immediate onset. You know exactly how much you gave. There's rapid push, where we're slamming it more or less, where we are giving it as fast as we can. Examples would be adenosine and then anything in a cardiac arrest. IV push is given over a few seconds, say 15, 20, 30 seconds. And then there's slow IV, like cardizem is given over 2 minutes, or amiodarone for Y-complex tachycardia is given over 10 minutes, that kind of stuff. IO is pretty much the same absorption speed. The problem with IO was that you couldn't give volume through that tibial IO, but as far as the absorption rate, it's pretty quick through there, fast enough, just not fast enough for adenosine. Adenosine's like the only one that you'd worry about. In a code, you're going to use it, use that IO and give things through that IO line, but adenosine for narrow complex tachycardia, or I should say for regular tachycardia, adenosine needs to go through a proximal vein, like a big AC line, and not through an IO. Other than that, the IO is pretty much the same as IV. And then IV infusion, what we mean here is a drip, so a dope or epi drip, and those as you vary the rate, you're going to get that dose varies as well, and so those are very fast, very fine-tuned absorption. I would add nitroglycerin drip. Nitro drips are another possible IV infusion. So that's just kind of an overview, pretty quickly, a brief overview of medication routes. I don't think there's any routes out there that we haven't mentioned that we would possibly use. There are a couple others, but they would never be used in the field environment, intrathecal and some of those. But these are the standard ones, and so as you start looking at med cards and you start working your way through cases and thinking about all this stuff, the route of administration impacts the rate of absorption, and that's the big idea from this one.